Good afternoon. My name is Sarah Steemsma, and I work as a family support specialist at Ask Resource Center. I'm going to be hosting this webinar. This session is Iowa Medicaid updates and a Q&A session. We have Director Elizabeth Matney here with us from Iowa Medicaid. She serves as the Director of Iowa Medicaid. She oversees Iowa's $6 billion Medicaid program, which serves more than 700,000 Iowans each year. She most recently served as health policy advisor for Governor Kim Reynolds. She worked closely with HHS on a broad range of critical issues. She holds a master's degree in Rehabilitation Counseling from Drake University and a bachelor's degree in psychology and philosophy from Texas State University. Her previous experience includes serving as Medicaid Managed Care Director, Medicaid Quality Assurance Director, and her early experience includes direct care as a Medicaid provider and work at a women's shelter. So thank you very much. And here is Director Matney.
Hello, everybody. I see. Thank you so much for putting who you are and what you do. I'm seeing some familiar names, although I don't see faces, but good to see. So for those of you that I've talked to, or you regularly participate in the town halls, a lot of this might be slightly repetitive, but hopefully we'll all learn something new and learn how to engage. And we have some exciting things to share. So I'm going to go ahead and share my screen, which is always fun with technology. So go ahead. Okay. So what's going on with Medicaid? Well, we got a few things we're working on, and we're going to talk about those today. So we're going to talk a little bit, just kind of big vision, what we believe and what we've identified our purposes here at Iowa Medicaid. We're going to give a walkthrough of our home projects, just some work that we did earlier this year with the legislature on some provider rates. We're also going to talk a little bit about Unwind, some updates related to our Department of Justice negotiations and the class action settlement, and then how to get involved. We have a lot of really wonderful opportunities to engage everyone. I am a strong believer that individuals in our communities, whether they're individuals who are receiving services directly or family members, caregivers, providers, you all have lived experience. And so we need to engage all of you on a regular basis to get perspectives in terms of where things are working well, where things aren't working especially well, what ideas you have to move the needle, etc. So lots of ways to get involved. And then resources. So if you're looking for something in particular, where can you go to find those things quickly? All right. So our purpose, we really are driven by our mission and our vision, which really surrounds a few different aspects. We want to be here to provide a program that provides equitable access wherever you are in the state to high quality services. We want to promote dignity, and we want to really focus on whole person care. And we do that through a number of different ways, including trying to find ways that we can be creative within our waivers, our state plan, our code, our rules to reduce administrative burden, to make the program easier to access, easier for our providers. And we also have to be good stewards of the taxpayer dollars that we are allocated each year, whether those are from the state general fund or from the federal government. We want to make sure that the funds that we do have access to are getting out there to promote good, high quality outcomes for the folks that we're here to serve, and that we're not seeing, or that we're seeing as little waste as possible and inefficiency as possible. Now, are we there? We are not. We are not there yet. But those are the things that we try to anchor in our day-to-day in terms of how we're operating the Medicaid program. And it's going to be a work in progress. There's no finish line here, but there are metrics in terms of where we want to achieve milestones to continuously improve the program. So one of the things that we are working on is really to promote the voices of individuals with lived experience, as well as being really open about what we're working on here at Iowa Medicaid. And so not everybody has an individual in their family or has access to all of the challenges that individuals with varying levels of ability face, whether they are aging or, Sarah, you popped back on. Is there?
So your slides are not advancing, so
Oh,
I
they're
don't know
not.
if you were meaning to or not, but we still are just seeing your very initial
Okay.
one.
Interesting.
I don't believe it's in presenter mode. I wonder if that's part of it.
Maybe. Let's try again. Can you see him now?
There we go. Now we're on the one that has our purpose.
Okay.
Yes, perfect.
Okay. So, back to the point about lifting up voices and being transparent about what we do. Not everybody has a lens or a perspective where they really know and fully appreciate the world of like home and community-based services, for example. And so we've been working with some volunteers from the community in terms of either individuals who receive services directly or their family members to give us a lens into what that experience is like on a day-to-day basis, where they're seeing things work well, where they're not seeing things work well, ideas for improvement, like I said earlier. And so we did create a new video. And Sarah, do you want me to go ahead and show that? Do you think that the group would like to see that, or just click in the link at a later time?
I think let's click on the link, and then maybe if we have time at the end and questions have been, then we can kind of go back and revisit it, because I do think it's a really great video. But because we could, capture it somewhere else, maybe for our time, that would be best.
That sounds great, Sarah. So yeah, we're going to be sharing this this video compilation. We have a lot of content to pull from because each one of these individuals was so generous with their time. We sat down with each person or people for about an hour to an hour and a half. So there's a lot of different topics that we focused on. And so we're going to be creating a series of videos that focus on different things, but really to provide access, more public visibility into these voices, including with our legislative partners, our federal congressional delegation, so that we're putting a bit of a human face on the experience as well. So our goals within our strategic plan are we want to improve services and make sure that they're available to everyone. So regardless of your age, where you are in the state, maybe your racial or ethnic composition, we want to make sure that services are accessible, including what your actual diagnosis is. And like I said earlier, we're not there yet, but we have some plans on how to move the needle. Goal 2 is to how updating the way that we're doing things, like I said earlier, looking at administrative rules, looking at our processes, because there are times where we're making things more difficult than they need to be. And you all are probably like, yeah, you are. And I get that, and I see it every single day. And so we want to make sure that we're evaluating the way that we work as a Medicaid agency to ensure that we're doing things in the least burdensome way possible, that we're not just collecting information or making people jump through hoops because it might glean some information that we might want to know. We want to make sure that we're doing things that have an actual use case or value to the overall system, including the individuals that we serve. And then goal 3 is really being open about how we're doing as a state Medicaid program. And that means not only sharing the things that we feel like we are most proud of and that we're doing well, but also showing where we're seeing gaps in the system, where we're seeing outcomes not rise to the level that we would expect, and then also what we're planning to do about that. You'll see that specifically show up in the new dashboard that we have publicly available, as well as our town halls and listening sessions that we're holding on a regular basis. And then goal 4 is to make Iowa Medicaid more modern and efficient. We have a lot of really old technology that we leverage. So our Medicaid management information system, for example, is older than I am. And a lot of people who are younger and coming into this industry are looking at the technology that we have and saying, okay, you can do better than this. And we agree. And so that has been a project that has stopped and started many times, but we're starting to make some progress as well. But in addition to technology, we really need to make sure that when we look at goal 2, that we're also making our workflows and our rules as least complicated as possible. I was trying to find like a good way to describe it, but as least complicated and as clear as possible, which we're not always haven't historically been the best at. So first, I want to talk a little bit about the home project. We've talked about this for the past 18 months or so. And you may have heard us initially talk about it as the community-based service evaluation, and then the community-based service transformation plan or community-based service redesign. Well, we decided here at Health and Human Services that this opportunity of really changing the landscape of the system, you know, it's a wonderful opportunity that we're faced with. The system really needs it. A lot of the rules and the way that our home and community-based waivers are structured today have been the same for decades, and it's time for a refresh. And so we rebranded the project HOME, which is an acronym, because here at Iowa Medicaid and Health and Human Services, we love a good acronym. We can make full sentences with nothing but acronyms. God help everybody around us that doesn't have the translator, but we are trying to reflect our priorities and our values within this project through the brand. And HOME stands for Hope and Opportunity in Many Environments. Really what that gets to is home and community-based services should be something that not only help people stay safe and stay well, but also helps people lift up to their highest potential, and that those services are here to do that. And really that they're here to do that wherever an individual wants to live in their community and however they want to interact in their community. So when we started our home project, some of you may recall, but I'll back up a little bit for those of you that haven't been part of the conversation over the last year and a half. In 2020, the American Rescue Plan gave states the opportunity to have some of their state dollars returned to them. And each state had to submit a plan to the federal government that outlined how they were going to basically reinvest those state dollars. And there were some primary tenets that were created as really the guidelines for how these dollars could be spent. And it was to really truly improve quality and access to home and community-based services. So when we took a swing at it, these are one-time funds. So we needed to be very conscious about how we would create sustainability. We knew the system really needed to get kind of a facelift, and also address some of the crises that we're facing, including the workforce challenge. And so we decided to use some of those dollars to invest in doing an evaluation of our home and community-based service program. It's not that our staff couldn't do it, although it is much easier when you leverage someone who has national experience and a deep bench. We needed to get it done quickly. And if we had kept that internally at the state, it just with limited number of resources, it was going to take too long, to be quite honest. And so we decided to go with Mathematica. Took 12 months to do the evaluation. Out of that evaluation came findings and recommendations, and those fed into the transformation plan. So when we think about the evaluation, there are kind of three main things that came out of the evaluation in terms of these are kind of general themes of what Mathematica heard and what they saw. So the home and community-based system just isn't working as well for some as it is for others. So when I think specifically, I think about, for example, children with autism or another developmental disability that doesn't have a co-occurring intellectual disability. Because we don't have a specific autism waiver today, and our waivers are constructed based on truly diagnosis as well as level of care, we have folks that are slipping through the cracks and they're not qualifying on the face of it for certain waiver structures. So kids who may have an autism diagnosis oftentimes are relying on the health and disability waiver for the services that they need. But guess what? Because those services aren't the same as like services on our intellectual disability or our brain injury waiver, they're not truly getting what they need. They're limited by the service package that is found for the health and disability waiver. So that's one pretty clear gap that I see, but that's one of many. And so just depending on what an individual's diagnosis is, the way that they come into the system and what they end up qualifying for, it might not meet their needs as well as someone who is sitting right beside them. Also, we looked at the system. There is a lot of money in the system. Whether, if you think about like the overarching system, which of course includes Medicaid. Medicaid's a really big part of it, but you also have our area agencies on aging, you have the mental health and disability service regions, you have schools. There is a lot of money in the system and a lot of resources that are available, but guess what? We don't talk to each other as well as we should or could. And so that is creating unnecessary obstacles and challenges for the children, the adults, and the families that we serve. Also, I touched on this a little bit earlier, but really services should be aligned at an eligibility level with the individual's need, not just strictly their diagnosis. And so thinking about how to rearrange things so that that would work better. So there are three big chunks of the transformation plan for home that we are working on currently. And when I say working on, I think that individuals have become accustomed to like 3 and 5 year plans, or, they just keep perpetually bringing up issues and nothing really happens with it. And I want to just say, I get it. I get that there's some skepticism that we're actually going to make this thing happen, but we're going to prove up the fact that we're going to make it happen. And we're doing that every day with how we engage individuals with lived experience in all of the planning that we're doing. But to give kind of a more precise timeline on all of these things that we're working on, like most of these things are going to land in 2024, early 2025. So in the next year, we're going to see a lot of big changes. So our goals from home, making it easier for individuals and their families to find the services that they need. We have so many doors. Back in 2012-ish, there was a lot of emphasis for states to create no wrong door. Well, we really leaned into that so excessively that we created so many doors and nothing connected those doors together. There was no lobby or foyer for people to kind of come together. And we need to bring that together. We cannot keep asking individuals and their families in times where it's super challenging. People are very stressed, times of crisis, to go searching on maybe 10 different websites, filling out 5 different applications. We need to bring all of those things together and make it more readily accessible for folks who are in need. Aligning services with people's needs, talked a little bit about that earlier. So we need to make sure that the services that we do set up in a home and community-based structure are accommodating the needs of individuals. And we're not arbitrarily saying you qualify for this or you don't qualify for this, even though the need is the same. We need to create a structure so that we can quickly and effectively match needs with services. And we need to create a system that better supports our case managers so that they are equipped and tooled up with all of the services and nuances of Medicaid, but also all of the service availability and things that are accessible outside of the Medicaid system, so that they can be that single conduit to help connect individuals and their families with everything that they need, whether it's a home and community-based Medicaid service, or it is food assistance or rental assistance. We need to skill up our case managers to be able to handle all of those things. So I know that wait lists, I saw some of the questions that came through, and wait lists are an area of concern for everybody. We have pretty significant wait lists. This is not the way that our waivers are structured, helps amplify this issue because people are on more than one wait list. We have 19,000 kind of like wait list slots right now. A third of those are individuals who are on more than one wait list. So if we deduplicate the 19,000+, we get down to a smaller number of about 14,000 unduplicated, distinct individuals who are waiting to get on a home and community-based service waiver. Well, we don't make good use of that wait time, and we should. And when I say we, I mean us, like specifically on the Medicaid side. So when an individual comes onto a home and community-based waiver, we don't do any type of screening to make sure that they're on the right waiver, or waiting in the queue for the right waiver, nor do we screen them to see what they need today. Like I said, there are a lot of resources in the system, and we should be connecting folks with the resources that are available while they're in line waiting. And we need to be doing that proactively and not expecting people to cobble those together themselves. So we are doing a point in time screening for all 14,000 of the individuals who are on the wait list. We are going to be doing that over the course of the next like 5-ish months, reaching out to individuals directly, asking them to participate in about a 30-minute screening. The output of that will help us determine the need of individuals at the aggregate level who are on a wait list today, but also get case managers connected to help support getting individuals what they need right now while they're waiting for an actual waiver slot to come available. Moving forward, after we get through this big 14,000, we will be doing the screening as each individual comes onto the wait list. So it'll be more of an as people stream in rather than doing a big bunch at one time. We're also working on getting information from focus groups, as well as working with individuals with lived experience to develop persona experiences to figure out like where are the actual tension points in the system so that we can mitigate those as much as possible. We are coming out all over the state beginning later this month through November to talk to individuals at a local level about what we're doing with the home project, when they should expect things to start changing, and get feedback on what we have planned so far. And so we have several locations all across the state. We also will have 2 virtual options, one in English and one in Spanish. And all of these locations, if you click on the link, once you get the PowerPoint, it'll give you the location, the date, and the time. We're very excited about these, by the way. So I'm going to kind of breeze through this one a little bit real quick. So there are a lot of things that we're doing related to rates. We're working on with our hospitals I'm not going to get into the weeds on this, but it's a kind of a different payment mechanism that we have never made full use of in the state of Iowa. However, a lot of other states rely really heavily on these, and boiling it down, it's going to greatly increase the amount that we'll be paying hospitals for inpatient and outpatient services. We're hoping that will help open up access to different service types, as well as better support our healthcare practitioners across the community. We also were appropriated some money during this most recent legislative session. We started this year, and it was our first year of doing this, but we are going to be doing it every year moving forward, where we do a regular rate review. And because we have so many different rates, we have so many different types of services and provider types, we're going to be doing half at a time. So half one year, the other half the second year, and then kind of repeating that cycle over and over and over. And what we're hoping to get to is a cycle where we can kind of predict what the rates, what the appropriations will be needed for each year, so that the legislature can go in and just be prepared for that, rather than wait for lobbyists and advocates to kind of figure out which one's the noisiest and which one can get their item included in the appropriation bill. We want to take some of the subjectivity out of it and just give an objective lens into where Iowa Medicaid rates are compared to different benchmarks. And so we did that this year. And what that showed was that a lot of our behavioral health providers, because they hadn't gotten rate increases for many years, were very much behind where we benchmarked specific services and rates. And so this resulted in a $7 million investment in individual mental health therapy rates, also a $3 million increase, a $3 million state investment in substance use treatment, and then a $3 million state investment in our PMIX. We have had some home and community-based service provider increases over the past few years. However, what I will say in 2023, that $5.5 million, we had used in 2022 that 4.25% increase. We were using those one-time American Rescue Plan dollars to fund that for 2022 and 2023. But we weren't prepared to do that unless the legislature would agree to continue funding that increase moving forward. And so 2023 isn't $5.5 million of new funding. They were starting to create that sustainability and appropriations to support the 2022 rate increase. That said, one of the big components that we are looking at for the home project, but overall, just in terms of looking at provider access across the state, we are looking at some investment opportunities on the home and community-based service side again for this legislative cycle. So we'll be talking to our governor's office as well as legislative partners to outline what we think the system needs in terms of rate increases, and of course working with providers as we put that proposal together as well. I'm going to skip the rebasing. Department of Justice and class action settlement. So I'll just rewind slightly to let everybody know who maybe isn't aware. In 2019, the Department of Justice came in based on a complaint and investigated Glenwood Resource Center. And that was on specific ways in which that resource center was operating. And out of that, there was basically two investigations. One was specific to Glenwood Resource Center. And then the second was specifically related to over-institutionalization of individuals with intellectual disability. And so when I talk about the Department of Justice updates, I'm talking about the latter piece. So the over-institutionalization of individuals with intellectual disability. That is a settlement that we are still in negotiations with the DOJ. On the class action piece, we were, I believe it was early 2023 or maybe late 2022, we received notice that we were being sued on behalf of children with behavioral health needs. And there were a few different assertions in that litigation. One is that sufficient case management wasn't provided for individuals with behavioral health needs. Also, that there wasn't robust enough community-based services to prevent institutionalization. And so we have come to an interim agreement on that. And I'll just skip to that real quick. So we announced on October 2nd that we are in a space where we have agreed on an interim agreement. What will come out of that is an implementation plan in terms of how we, Health and Human Services, are going to work to address each one of the things that we have agreed to move forward. So improving case management certainly is one space. doing a comprehensive needs assessment on our provider access, both from like, do we have enough providers across the state from a brick and mortar perspective, like how far away are providers from individuals, but also what do wait lists look like and what do staffing needs look like. So we're going to be looking at that and then addressing it through very specific steps. And then also, this is where the home project ties into it, is making sure that we have the right service package for kids to access that prevents institutionalization. This is anecdotal at best, but our children's mental health waiver is our home and community-based waiver for kids with behavioral health needs. And oftentimes what we see is that even though there are 4 services offered under that waiver, they might not be the right services, because truly the only service that we see individuals access on a regular basis is respite. Now, does that mean that does that mean necessarily that those aren't the right services? I don't know yet, but we need to look through that a little bit more, because right now, not very many folks are leveraging some of those in-home options. And we need to get to a space where we're identifying, if that is not a value add to the family and the child, then what is? And so that'll weave together with this class action settlement as well. On the DOJ side, like I said, we're still really in negotiations, but we know that there are some pieces that overlap between the Department of Justice findings on over-institutionalization and the class action lawsuit. And those really focus on making sure that we're doing regular assessments of the provider access and service access, regular assessments in terms of, are those services working? Are they providing high quality results and improving individuals' lives? So we need for both of these things to have an initial plus an ongoing needs assessment developed. We need to improve case management. So now we're improving case management for kids with behavioral health, but also for individuals with intellectual disability and developmental disability. Well, we're doing it for those 2 populations, we might as well do it for everybody. And so a lot of the solutions that we're coming to on the Department of Justice side and the class action side, we're weaving in as much as possible to the home project, but also making universally applicable so that we're creating a better system for everyone and not just the individuals identified in these 2 lawsuits. Also improving crisis response services. That was another important piece of the class action lawsuit as well. Increasing some slots, having a better quality management oversight system at the state level. We do many things today. We have critical incident reporting, we have provider compliance monitoring, but these things don't always intersect in the way that they should be so that we can see the big picture all at one time. So we're going to be working on how do we build a system that pulls all of those things together and can provide Medicaid, Health and Human Services, case managers better visibility into the aggregate results, but also at the individual level where there might be risk indicators that say we need to do something different because things are not getting better or things are getting worse. All right, I'm gonna kind of gloss over some of the unwind just a little bit and focus on some key takeaways that I want you to have. So when the public health emergency requirements around continuous coverage decoupled and really ended at the end of March 2023, We had been planning and planning for like 2.5 years, preparing for this unwind process, or the process by which Medicaid's going to start doing redeterminations again and look at true eligibility criteria in terms of who's staying on the Medicaid rosters and who is not. It seems like over the past 2.5 years, we've all gotten out of practice. You know, this was something that was every year, pretty regular. People had their redetermination paperwork, they got it back in, and we've gotten out of practice, like I said. So we're trying to figure out all of the ways that we can reach people more effectively. And Sarah and Mari, what I will say about this slide is it looks like we put X's in place for a real number. So before you publish this PowerPoint, I want to make sure that Emily gets that included into the PowerPoint for information. So one big takeaway that I want all of you to have is that we do not want people who need Medicaid and are eligible to Medicaid. We do not want them to ever lose Medicaid, especially for something as simple as not returning a piece of paper. And so all of that said, things happen. And once, if you or someone you know does receive a disenrollment notice or becomes aware that they have become disenrolled, please get in touch with us. Call our contact center. We will help you process and fill out your application form on the phone. We'll make sure that the application or redetermination paperwork gets processed as quickly as possible and that you have no gap of coverage, especially if you get back to us within the 90 days since coverage was lost. We can go back, reinstate coverage to that date where it was lost and have no gaps in coverage. And that really is ideal. Ideally we want to get it right the first time, but if that doesn't happen and somehow the paperwork is not submitted, we want to make sure that there are very quick pathways to get back on Medicaid if it is indeed lost. So here's a little bit more information related to that, and then how to get involved. If you are interested in becoming more involved with some of the work groups that we have, please do come to our town halls. That information is found on our website. If you just Google Iowa Medicaid town halls, it'll take you straight to that page. So I would encourage you to start there. But also there's an interest form specific to the home project that I encourage you to fill out if you are specifically interested in participating in that. We are always looking for more voices to come to the table. We also have some information related to how to escalate a need. And I say that because oftentimes people are like, well, who do I go to if I'm having a problem with my case manager? Who am I going to if I'm having a problem with my provider? What if that doesn't work? Then where do I go? And so we did go through this maybe last year and then refreshed it with Molina now in the picture. And there are, it is on our town hall website as one of the supplemental materials, but I believe if you go to this, yeah, you can click right on it. Also, we have a dashboard if you're curious at all about Iowa Medicaid program outcomes, some basics around who we serve. We have a new dashboard that came out in July. We did some soft launch of that, got some feedback on things that weren't clear or needed to be changed, and we updated that. There's a lot of information in here. If anybody has questions, feel free to let me know. We also would be happy, Sarah, if at any time wanted us to do a walkthrough of the dashboard and help people understand some of the data, we would be happy to do that as well. Okay, that was kind of like the quick presentation, and I've been talking for a long time, but I also have some Q&A. So the last time I saw you, there were a number of questions that didn't get answered. And so we put together some answers for all of those questions. And there are a few that I hope got answered during the presentation, but there are a few that I wanted to highlight, and then I'll just open it up for questions. So if we're changing from a diagnosis-based waiver to a needs-based waiver, will that remove an individual from the waiver if there are individuals with greater need? Absolutely not. Once you have a slot, you have a slot. That said, we have to abide by the federal regulations where you're using, in order to maintain a slot, you have to use at least one waiver service in a quarter. Otherwise, that's the only way that you can lose your waiver slot. Another question is, since moving from South Dakota last year, we're not able to get on Iowa Medicaid, got on the wait list for health and disability and intellectual disability, and was told it's going to be 4 to 6 years. Daughter's 12 years old, and it will be too late for all of those therapies to be as effective as they can be. What can we do? So this is one area where there was also a disparity, but we have priority needs assessment forms that you can fill out if while you're on a wait, you have the risk of institutionalization or some poor medical outcome. You can fill out this priority needs assessment. Historically, this has only been available for the ID and the intellectual disability and the brain injury waivers, but we are making it accessible across the board because there are varying levels of need, and we want a pathway for those at risk, regardless of what the diagnosis is. It's really, really important. So if you don't know how to access the priority needs assessment, again, Google is our friend sometimes. But if you just Google Iowa Medicaid priority needs assessment, it should take you right to that form. How can families get training on CCO? The ISB says that that's the MCO. The MCO says it's the ISB, and no one answers questions, just denials. Wow, how annoying. Yeah, families definitely should contact their case manager for this, and we're going to cascade this information out to our MCOs as well. Christy Casey is one of our long-term services and support staff, and she has volunteered her email as well, and said that she would be happy to assist also. She also said that you can reach out to your home and community-based specialist in the area, but I will, after we're done here, I'll send these questions and answers out as well, so everybody has information. Will Iowa ever get state-run PMIC availability? My daughter had to go to Utah, and as a parent, it breaks my heart. It would, me too. We are working right now on a lot of effort to try to get our PMIC providers in the state to expand, but also to specialize in some areas that they're not specialized today. PMIC, good question, Cynthia. Sorry for the acronym. Psychiatric Medical Institution for Children. And so right now we don't have a whole lot of access for kids who have co-occurring intellectual disability and mental health challenges, which, you know, how often does it happen where a kid only has mental health challenges? They usually have other needs as well. We also have some challenges with finding places for kids that are aggressive or have problematic sexualized behaviors. And so we're trying to work with our PMIC providers with this most recent appropriation, to leverage those dollars to specialize in some of these areas where we are seeing kids go out of state. Also, just frankly, workforce challenges have not allowed for PMIC providers to fully staff all of the beds that they have available. And so this increase is also, we're hopeful, will allow PMIC providers to staff up so that they can open all of those beds and increase access in the state. SB did put in the chat something about dental, and that was one of the ones I was going to talk about as well. So we have talked about this on some of our town halls, and I'll give you a little bit of a national perspective as well. But we are currently working on I'll just say this. Last year, dental services was one of those things where we did the rate review. So we looked at all of the ways in which we pay for dental services. We benchmarked them against other state dental programs and discovered we're overpaying for an orthodontia about $6 million a year, and we're underpaying some of our other key dental services. And so we're working on a proposal to get some final approvals for where we're reallocating those payments for orthodontia over to preventative and diagnostic services so we can up those rates. It'll be about a 20 to 25% rate increase for those specific types of services. We're also working on a couple of other ways, including, maybe expanding our iSmile program, which goes across the state. Very effective, very good outcomes. They are also able to connect individuals in a better way with specialists that they might need to see. They are also going into nursing facilities, and we're looking at can we get them into HCBS settings as well. So we do have a lot of things working on the dental side. I know it's not quick enough, and it really is hard. It's hard when you're not on Medicaid to get an appointment faster than 6 to 8 weeks. So I totally get it. Okay, Sarah, I've been talking. Do you have some other questions you would like me to address?
Well, I think that Mari and Emily have been kind of in chat, as people have been listing things. There are quite a few things that people have posted in the Q&A. A lot of them are very specific to a need they have. So I thought we could maybe just talk through how there is a system you already have in place, that if people have a specific question that they would like addressed, I had shared the email earlier, and I can have Mari maybe cut and paste it. So the Iowa town halls, they happen twice a month. I also posted on here the archive where people can go and see all the past presentations. So the dental presentation that you talked about in the past, the actual slide deck for that is available if families want to go and look, or providers want to go and look at what's been provided there. Also, then there's that Iowa Town Hall email address. I would encourage families. Now, Director Matney has said she'll work with us to get answers to it. But if you want in real time to be asking your question and getting a response, that Iowa Town Hall Medicaid, that is where you could go to ask a lot of the questions that were posed in the Q&A, specifically to your case, specifically with ideas on, is there a service or something that's available in this situation I'm finding myself, where can I go? And I think if you're in agreement that that's a really good first step for families in terms of how can they get their question answered. And also then looking back through some of those town halls, if they aren't able to attend live, reviewing what has been discussed. A lot of times on those PowerPoints, there's even specific names of, who is kind of running that project and who would be the best person to reach out to at Iowa Medicaid to get the right question directed to the right person. Would that be an accurate statement? Oh, I think you're on mute.
Well, that's not helpful. Yes, absolutely.
Okay. So think what we'll do is we'll just say, you know, we have a few minutes here that we're going to close everything up. So if you have an ongoing question that you had put in the Q&A, I'm sorry that we ran out of time today. Please use the town hall email address. We'll see if that's gotten dropped in here recently.
I put it in there.
There you
a
go.
few ago,
Okay,
yeah.
so if you guys can find that, that would be a really great resource. Also, the contact center that Emily has placed. Thank you, Director Matney, for presenting today. Thank you to everybody who attended this session of Iowa Medicaid update and the Q&A.